Dear colleagues, this is another interesting case. We have an intumescent cataract here, a patient that was delaying the surgery too much, and under irrigation from the AC maintainer, I'm trying to take the pressure out of the bag using the cystotom, aspirating the cortex, and watch very carefully this boom. Pressing down on incision will depress the posterior side of the incision. Leakage from that will make an AC without pressure, and losing pressure into anterior chamber in this intumescent cataracts lead to the Argentinian flag, as of course we all know. But this is not a tragedy anyway. We have a V-shaped Argentinian flag here, and treating the case like a routine one. Just to be more careful with the aspiration and with the rotation of nucleus and cracking of nucleus. And if we separate the pieces laterally, we should do it in a controlled manner and not having the pieces separated too much. So here it's a lateral chop, and see I'll separate just a little bit. Lateral movement, I'm trying to keep it to the minimum. Another lateral chop here, and just teasing out that part of the cataract, the nucleus, and it's very, very light nucleus, is not a hard one. So it's very easy to aspirate it just using very low ultrasound power. And the bag is already decompressed, so it's no more problem to do any phacoemulsification now. We are out of the danger zone. We cannot fear that the capsulorhexis will run to the posterior plate anymore, to the posterior capsule anymore. But still, we have to manage the case slowly, without rushing. There's no rush in these cases anyway. We should take it slowly. And notice the fact that I keep the phaco probe well inside the eye, because I have the anterior capsule in a V-shaped form, and I don't want to catch it with the phaco needle and accidentally aspirate, and that will extend your capsulorhexis to the not capsulorhexis, but the anterior capsule tear will extend it to the posterior capsule also. So we have to keep that in mind and stay away. Either you trim that with a scissor from the beginning before you start the before you start the phacoemulsification, or just stay away from it during phacoemulsification, and always pay attention not to catch that part of the capsulorhexis. And in this kind of cases, I prefer to inject the IOL inside the bag, and then take care of the cortical remnants and aspirate the cortical remnants when I have the IOL inside the bag already. And that's the last piece of the nucleus. Notice the fact that I keep the chopper down to protect the posterior capsule. I'm not taking out the phaco probe from the eye until I'm filling up the bag with viscoelastic, And injecting the IOL, I try to keep the haptics 90 degrees away from the part where the anterior capsule is run into the periphery. I believe that's a position that keeps the IOL more stable inside the bag. Thank you for your attention. Hope this will help you in your practice also.